Welcome to a day in Implant Center of Miami. I'm Dr. Herzog, and today we're in the Coral Gables location. We've got several implants today and so many different consults. I'm here with Dr. Cowan today, and let's go.
For him, take the tooth out, let the gum heal over on its own, then come back and do it with fully closable
but
tissue.
The surgery part would be open up again the gum and then.
Right. Yeah, go in the same area, except instead of there being a big hole that I got to figure out how to close, it's now closed, so it makes it easier to work around. Again, a couple times a year, so not a routine.
No, I just want to know how the surgery goes.
February 26th.
So the same numbing that you do for taking the tooth out, you just numb the front and the back. Take the tooth out, a couple of months, give it just enough time for the gum to fill up. Same numbing, and then you just go in there and do it like that.
Okay.
Las caries salen porque queda comida entre los dientes. Yo no lo paro, pero sí.
Y no solamente los dientes, pero el diente y la encía.
Oh.
Ahí es donde la bacteria se queda y después eso destruye el hueso que aguanta el diente. Más importante, porque eso no tiene síntomas.
Ya.
A ver, sonríe un momentico. Number 12, implant, and a guide. That's it. El implante que nosotros usamos es de la misma familia de los tornillos de la columna.
Exacto, que son así de titanio.
Yeah. En la misma compañía que lo fabrica.
Lo que me interesa saber es cuánto me va a costar.
El implante es 1,789. Si lo hacemos sin guía, con una guía quirúrgica le aumenta un poquito, no sé exactamente.
¿Qué guía?
Una guía es hacer la cirugía en la computadora primero para que quede perfecto, rectecita el implante sin tener que pensar, o eso lo hace muy preciso.
Sí.
Pero eso sí se tiene que fabricar y demora como 1 o 2 semanas y después se puede colocar el implante. Sin la guía solo es...
Es como una cosa que ponen así para que se guíen por ahí.
Imagina si vas a poner el televisión y ponen la guía esa para poner los huequitos del...
Sí.
Ajá, así, pero mucho más
Claro,
avanzado.
Claro.
Ya, es para la fresa, para que la fresa no va muy profundo o a un ángulo que puede tocar otro diente. Ajá, exacto. Some people might think that we only do implants here, but actually we have a full hygiene program. And you can see this is Adrian. He is doing a scaling right now. And so he's one of our hygienists. And we like to make sure that you maintain your gums healthy and your implants so they can last a long, long time.
With our upper jaw, we have our sinuses, which is like an airspace in our skulls. Typically, the roots of the teeth hold the sinus up. So when that tooth was pulled, just in that area, and I'll show you in a second on the x-ray, on your other teeth, the roots are kind of being like tent poles. So when that other tooth was pulled, the sinus dropped down a little bit. Doesn't mean you can't have an implant. It just means that we need to do a couple of extra steps to get an implant in there. For long-term implant stability, you need a certain amount of bone width. So it needs to be so wide and so tall. The bone width you got, the height is a little bit reduced. So what I do in those cases is what's called a vertical sinus augmentation. I basically go in and internally, so while I'm doing getting the implant in there, we'll lift up your sinus from the inside so we can have an implant that's long enough that we can know that it's going to be stable long term.
Okay.
So on the top right hand side, we would do the vertical sinus augmentation the same day that we place the implant, and you let that heal for about 4 months. Okay, it'll be healed, covered up by the gum tissue, so it'll be just like it is now. After it heals, we'll do an uncovery, which is where we get you numb, we put a healing abutment on, and that's like a metal cylinder. Its job is to shape the tissue and the shape of the tooth that is to come.
Okay.
After we let that heal for a couple of weeks, we scan you for the crown. So that's the upper right-hand side. The upper left-hand side, where you have that tooth that's broken, pretty big break. There's a lot of decay on that tooth. So much so that after I go and clean all the decay out, there won't really be a whole lot of tooth left.
Okay.
So the order of things I think we need to do on that side, I think we need to take that tooth out, do bone grafting at the same time we take the tooth out. So you have a tooth, you take it out, there's a socket left. We put bone graft material in the socket to help reduce the amount of shrinkage that naturally happens if no bone grafting is done. So that way we preserve the height and we preserve the width of the bone, so that after that heals for same time, about 4 months, then we can get the implant in and we know that we maintain what was there. With the broken one on the bottom right hand side, it looks to me there's some decay, but the tooth is savable. So it would be a buildup in a crown. What the crown process is typically 2 visits. On the first visit, we remove any decay, any old fillings, we clean it up, we build up any undercut areas, and then we take a scan. The scan goes to our lab to make the porcelain restoration. You leave that day with a temporary crown. 2-3 weeks of wearing the temporary crown, we just ask you to take it easy because it's in there with temporary cement, because we got to be able to take it out. Once the lab makes the porcelain restoration, we bring you back in, we take your temporary crown out, we get the porcelain restoration, adjust it, and we cement it on in there.
Okay.
At the end of that process, the crown goes in, it stays in. It's not something that you have to take out. You brush, floss, clean it, you do everything just like it was a normal tooth.
Este es el huesito suyo, la mandíbula. Aquí tenemos este círculo aquí, es el nervio mandibular que da la sensación al labio. Okay. Normalmente del nervio hasta la parte superior del hueso tenemos como 12 o 15 milímetros, 1 centímetro o más. En su caso, solamente tenemos 6 o 7 milímetros. So es bien pequeño. El implante más corto que tengo, que no me gusta usar porque es tan chiquitico, es de 6. Y usted tiene 7.5 de hueso. So la diferencia es el grueso de una tarjeta crédito. Para que entiendas, 1 milímetro. Okay. Se puede hacer. Pero hay riesgo y poniéndole un implante tan pequeño, ella va a sostener una muela más grande. Entonces la fuerza es mucho para ese implante pequeño. Ahora le voy a revisar los dientes a ver qué tamaño se puede poner ahí. Aquí casi tienes 10. Ahí estamos bien. Y el grueso está fabuloso. Las segundas muelas, la que tienen infección periodontal en este momento, esas casi nunca se van a reemplazar. La infección le ha comido todo el hueso alrededor de la muelita y ahí está el nervio. ¿Ves? So, en esta situación tenemos que sacar la muela, injertar esta área, ¿ok? Porque no queremos dejar ese defecto. Aunque te pongas implante o no, no le quiero dejar un defecto así de la mandíbula porque se te puede partir. Y maybe en 3 meses o 6 meses podemos evaluar si te quieres poner la segunda muela, pero no se lo recomiendo. Con una muela es suficiente. Ahora, si le vamos a poner estos implantes chiquiticos, maybe es necesario poner 2 implantes y unirlas. So, ahora le voy a mirar todo y le aviso. Otra opción es reemplazar todo. Quitar todos los dientes de abajo y ponerle una prótesis fija, que eso se hace en 24 horas. Se sacan los dientes, se ponen 4 implantes alante del nervio. Esto no es exactamente lo que es, pero son 4 implantes que soportan todos los dientes. Y es atornillado, es fuerte.
Pero con tan poco hueso, cogería.
Es más fácil hacer este procedimiento cuando hay menos hueso. Porque en este procedimiento podemos angular los implantes alante del nervio, donde tenemos hueso, para llegar atrás. Y le ponemos 4 o 5 implantes en su caso para poder sostener, o hasta 6 implantes se puede poner, para mantener todos los dientes. Y es hecho de circonia con una barra adentro de titanio. So, va a ser los dientes más fuertes que usted ha tenido en su vida.
Sí.
Ese procedimiento lo hacemos maybe entre las 5 oficinas todos los días. Es algo
En
que
un solo día.
es 24 horas. So, te hace la cirugía,
El primer día.
le sacamos los dientes, le ponemos los implantes y le tomamos una medida digital. Vayas a la casa sin los dientes, con una
Ujú.
mascarilla. El próximo día a las 3 de la tarde, por ahí, llegas y sus dientes están aquí y la atornillamos a la encía. Después de eso, hay que cicatrizar, ¿right? Es un proceso de cicatrizar el hueso con los implantes. 3 meses de comer comida suave. Después de los 3 meses, se cambia esa prótesis que le pusimos en 24 horas a una bien fuerte que ahí puedes comer chicharrón.
Okay.
¿Se explicó bien?
Yeah.
Puré hasta chicharrón.
Hasta el chicharrón.
La circonia no se mancha o puede ser una mancha superficial que en la limpieza eso se sale rápido.
Y no tendría sensibilidad, porque yo tengo sensibilidad.
Actually, no tienes ninguna sensibilidad porque no vas a tener dientes. Los implantes no tienen sensibilidad.
Y como están encima de
La encía, si se limpia, estás bien. Los implantes pueden coger infección periodontal si no se limpia bien.
Tengo que seguir con la limpieza
Cada
profunda.
3 meses. Ajá, la limpieza cada 3 meses. Puede ser que una vez al año le sacamos la prótesis, limpiamos alrededor de los implantes y la atornillamos de nuevo. No duele nada de eso, porque los implantes están arriba de la encía, entonces solo es como quitar algo y ponerlo. Tienes que usar el water pick. ¿Sabes lo que es? Es como una manguerita de agua que echa agua, como un cepillo eléctrico.
Ya,
pero
yo lo tengo. Yo lo uso.
¿lo usas?
Ujú.
That's it. Ethan's chief complaint is that she went to the dentist and they told her that her lower molars needed to be removed, and she's concerned because now she won't have any molars on the lower, and she's not going to be able to chew properly. In the anterior, she has from canine to canine a splinted composite restoration that they did because their teeth were so mobile so that they can stabilize her. The premolars are stable on the lower left. Everything else has mobility. Okay. So, her concern is all the teeth on the lower. The upper is stable. Okay. When I initially looked at the edentulous positions, I was looking here and you can see that she's just got, 9 millimeters, almost 10 millimeters of bone there, but really good width. So that's what the one I was saying that maybe you can put an 8 there.
Yep, agreed.
A 5x8, just to get that posterior support if possible. It's close, but maybe guided. On the right side though, it's too short. She's only got like
6.
Yeah, 6, 7. 6.7. Okay, and then she's got this massive infection on 31 that is just destroying the bone. And so it's important to graft that so that she doesn't have any pathologic fractures or anything like that.
Yeah.
But when we're looking at the front, I think she's a perfect candidate. Look at this bone.
Very nice.
It's beautiful.
Looks like a good case. Yeah, especially with getting that molar on this side here.
Yeah, because you're going to have plenty of support in here.
Yeah.
Now, I don't think you're going to be able to get anything back here unless you put, nothing. There's nothing you can put back there. That's a little,
It's
just too close.
Too close.
Yeah. So, and then she said that she had these teeth removed 25 years ago.
Yeah, that happened.
And then she's been holding off on this one.
To try to save.
She's also been getting SRPs and perio maintenance, but this is full of calculus here.
Yeah. I bet it's tough to get 10 millimeters sub G to get all that calculus and stuff on that one.
And this one has a
Frication.
friction involvement. So it's a very basic, straightforward case, and the patient has mobility, periodontal disease, and so she's concerned that she's losing all her lower teeth, which she is. And the best thing to do would be to get ahead of this before she loses more bone. So for example, on the right side, the patient waited 25 years, and now she only has 6 or 7 millimeters of bone in that area. And the shortest implant that we would use is a 6 millimeter. And even that is very risky because if you lose just 2 millimeters, you've lost 30% of the bone around the implant. And so we don't really want to kind of play in that area. So we'd rather place the angled implants so we can get to the back as well, and then place 2 straight. And if we can put 1 on that left side or 1 in the midline, that'll be sufficient for her. And she's a petite woman, so this will be perfect. Yeah, very straightforward.
Hello, hello. Dr. Callan. How are you? Yo hablo español un poco. Toma muchas medicaciones.
No.
Tiene diabetes. Bueno. All right. Let me do. I looked at the CT. Bone looks good. Mm-hmm. It does seem like there's a little bit of a tissue defect. Mm-hmm. So we'll do implant number 9. Oh man, the Maryland is loose, very mobile. See?
Uh-huh. Yeah, it looks like it's broken.
Yeah, fractured on the X-ray. Yeah. So we'll do implant, connective tissue graft, and crown. Number 8, and we can do the tissue graft. Well, I'll have you chat with him a little bit. We want to see if he's wanting an immediate temp or if he's okay with waiting in a flipper.
Anything bothering you on the upper left on the molar there? There's a little suspicious area around the root there. Looks almost like an abscess. So she's missing 19 and 20. I'll check to see if we can put 2 on that side. And then we can do number 30. So do 19, 20, and 30 with a surgical guide. And then number 3 with a lateral sinus lift, PRF, a membrane, and a surgical guide. Okay. You know, you have a tiny jaw, but the good thing about your jaw is that your nerve is really low.
Yeah.
So we have some space to work with. On the top, right, you don't have bone there. I'd have to graft it with a sinus lift, wait 6 months, then put the implant, wait 6 months, and then you can get a tooth. But on the bottom, all I would do is scan you, make a surgical guide that snaps on your teeth before I do the surgery so that I can put the implants exactly where they need to be and make sure we don't hit any nerves or anything like that. You cannot put an implant on the top right now as it is, as it stands.
Yeah.
But we can do a lateral sinus lift where we go into the sinus, we lift the membrane up, we put a nice golf ball size of bone in there. That hardens over 6 months. And then after that, you have sufficient bone and you can place the implant.
Okay.
It takes a year for that. And then I'll do your surgery on the computer first, and I'll virtually place the implants exactly in the bone where I want them before you even come in. So if at some point, which I'm not expecting, so I already measured it. But if, for example, let's say, I don't know, I was rushing and I didn't pay attention with the patient, which is not going to happen. And then I go to do the surgery virtually. I say, oh my God, I don't have enough bone. At that point, I have to call the patient and say, hey, sorry, it's not going to happen.
Okay, so it's possible
Yeah,
that you find there's not enough bone.
no, there's enough bone. I just measured. I just measured it.
Okay.
But if you'd like a comprehensive exam, we're going to take a full set of x-rays of your mouth, check for cavities, measure your gums, do TMJ evaluation, cosmetic consultation, all of that. We could schedule that for a different appointment. The surgical guide is an important piece for you. I won't do your surgery without it because you don't have abundant bone, right? If you had abundant bone, I can place that implant wherever and we would be great. But you have a very specific limited bone in order to place the implant. So it has to be extremely precise. The guide is going to snap over your teeth, and then my drills can only go in one position. They can only go to one depth, okay? So I snap it over your teeth. I make the 3 holes because you need 2 on that side and 1 on this side, okay? I make the 3 holes, and then I put the implant in and a cover screw, and I cover it with the gums. 3 months later, you come back, we uncover it, and scan you for your crown.
How do you cover it with the gum?
I make an incision, I place the implant, and I close the incision. Okay, so on the top jaw, on the back there, you only have about 2 millimeters of bone. Think of 2 credit cards stacked together.
Mm-hmm.
That's not enough for a screw.
Yeah.
But the sinus is an air cavity, right? With a membrane in it, kind of like an egg. Think of that thin membrane that the egg has.
Mm-hmm.
So we break the shell, which is the bone. We do it from the outs, in your mouth, but from the outside surface. We lift the gums, we make a little hole, we push that membrane up, and we fill it up with bone and growth factors. We close it. That procedure, you have your mouth closed for most of it. I'm in there, but it's very relaxing, and it has a really good prognosis. So of all the bone grafts in the human body, that's probably one of the most predictable ones. Okay. And there are always risks and complications and side effects that we can go over, but it is very predictable. And then you just wait 6 months until it hardens. And then we make the surgical guide and put the implant in. All right, guys, that's a wrap. Today we had, oh my gosh, so many new patient consults. I want to thank everybody who came in and trusted us to evaluate their situation and, give them the true implant that they deserve. We also did several surgeries. You got to see a little bit of Dr. Cowan, us explaining what is a sinus lift and what are implant placements, how we use surgical guides, and even do some guided veneers. So I hope you guys enjoy this. This is Dr. Herzog, Implant Centers of Miami.